I think you're, okay. Okay, so we're going to do a cervical challenge. I'm pulling up one of the more challenging cases, 13 neck surgeries. So there is only one movable bone, okay? But you have to know which way do you want to move it. Do you want to move it forward, sideways, backwards? What do you have? I mean, the x-rays are going to give you an anterior and posterior view. You can't get a lot from this because the body is going to be changing and adapting depending on the stressors or force loading that she's going through during the day. Yeah, 7 back surgeries too. I mean, you got to like the salesmanship of this. You know, surgery 9, don't worry, honey, a couple more will get you down. Okay, so this is going to be absolutely vital to understand how to assess C1. Okay? So volunteer, face down. Okay, so what we're going to do, we're going to assess the C1, which direction it needs to go. Now, we're not going to adjust C1, I just want you to practice a cervical challenge. And this is ideal because I get calls from patients around the world and I say, get your neck checked, have them do a cervical challenge, and guess what the answer is?
How do you do that?
What's that? Yeah, drive me crazy. Okay, so what you want to do before you touch the person up here, because every time you touch them, you're changing sensory input into the brain. So if you're going in and palpating like this, you're going to have a false reading. I'm doing it now because I'm not going to actually adjust her. Okay, so what you do is you check the leg length. You line up the butt, middle of the knees, feet, and you push in on the heels and you look down. You have to get your head in alignment because if the feet are like this or like that, it's going to be not accurate. If you're pushing up so hard that you can move the body, see how the whole body's moving? That's incorrect as well. Okay, so you want to line up the body, line up the feet. Hopefully you're doing it with the shoes on. It makes it a little bit easier. Get your head right down so you're in the plane, and then you can see which leg is not appropriate, okay, or if they're off. And you can say, well, what if they have an anatomically short leg? Still doesn't matter. This is still going to be appropriate. Okay. Then you come in, and you go right along the suboccipital area, and she has an increased in tone on the left side. Now what I'm going to do, I'm going to guess that it's posterior. I'm going to apply about a pound of pressure in the direction I think it should go. Okay, so what I'm doing, just for 4 or 5 seconds, and I'm using about a pound of pressure, then I come back here, and the legs, bummer, they're even. Well, I was kind of hoping it'd be off. But what's also cool, because I want you to go through an experiment with this, I happen to guess right. So also guess wrong. I mean, she's a student. And who are the people on the planet that have the most messed up spines?
Students.
Yeah. Chiropractic students. Yeah, so let's mess her up. So what you're going to do, you're going to hook the transverse process of C1, and I'm going to pull it in an anterior to posterior direction. So I'm actually moving it backwards from what her body just told me it should be. Okay, so I'm hooking it and applying pressure from the front to back. And then I'm going to check back here. Sure enough, absolutely horrible. Wow. Okay, I know. Thank you. And so what I want you to do is break up into pairs and feel just your hands are going to go along the occiput. You're going to look for an increased tone. Okay, first you're going to line up and check the leg length, and you're going to apply pressure in the direction that you think that vertebra should go. And if it makes it worse, try the other direction. Okay, if you don't see a change, because it could be posterior, it could be anterior, it could be lateral. This side could be increased in tone, and it can actually be the opposite side. So start looking. I mean, the other office that I worked with, we had 3-dimensional upper cervical x-rays. So it gave you a little bit more detail, but they don't have digital 3-dimensional upper cervical x-rays. My first chiropractor that I studied with was an ASBE doctor, Applied Spinal Biomechanical Engineering. And we did 13 views of the upper neck area using 1200 speed film. So every office should be focused in on this because that's more than a little important.
Hey Doc, will you explain when you push the atlas in the proper position, how it evens out the paravertebrals, evens out the pelvis? Because I never heard that.
So. That's brilliant. Okay, good, thanks. I forgot. This is why it works. Yeah, so that means I don't just say 'cause. Okay. Well, you don't have conscious control of these muscles. They increase in tone under proprioceptive firings. Okay, so if this is subluxated or putting increased tone or changing proprioceptive firing, it is going to increase the tone of this muscle or this side. You know, it's not going to be side specific, but there's going to be an asymmetrical firing of this. Since this connects down here, if this is increasing the tone, it can actually change the shape of the pelvis. So when you decrease the tone, it's going to change the tone of this. That's going to change the force loading on the pelvis, and that's going to change the leg length. Okay, so I mean, to just go over it, if you've got some change in proprioception, because this is not moving C1, this is changing brain function. When we're practicing the toggle, that's not moving a bone, it's changing brain function. You guys are nerve doctors, not bone or muscle doctors, okay? Would you ever want to relax a muscle? No. Not until you find out why it's firing. Good. It won't hit you. Okay? So understanding that we don't have conscious control of those, that they increase in tone depending on your view of your body's position in space or proprioception. Okay, does that make sense? Was that a good explanation?
Yep, that's good.
Okay, good. Okay, so this is a cervical challenge. And the question is, okay, let's say you assess it, you find out that it's good, you go in, you set the toggle, you turn it in the appropriate direction, set it down like that. Did you get it? I don't know. Let's check. So what you do is, you do the post check to see if you made the correction. Now, if you hear a pop, did you do an adjustment? So you know.
No.
No.
Good, because where do chiropractors live? We live in the paraphysiologic range of motion, okay? And what are the ranges of motion? And this is important you understand this. We've got active, right? We've got passive, which is more. We live paraphysiologic, okay? But you're only there for a fraction of a second. So here, go face down. So what you're going to do, after you've assessed, okay, after you've adjusted, okay, because you want to make sure that this thing is set, what you're going to do is do a motion check. Okay? You're going to get back here, check your leg length, and say, okay, now watch. Don't move your head yet, okay? I'm going to say turn your head to one side. I don't care what side or anything. Because if you say turn your head to the right, was that the right, Doc? No, you just turned it to the left. Okay? So say turn your head to one side, but I don't want you looking at her head. Look at this. 50% of the rotation of the neck occurs at the C1, C2 joint. So if you've already completed that, then you should see the legs move a little bit and then even out. Okay, so turn your head to one side. Good. Turn your head to the other side. Good. Go right back in the middle. So that's doing a post check. Turn your head to one side, turn your head to the other side. And what you're going to see is if you see it move out of sync when she's moved to one side or the other, then you need to go back and recheck it. Okay, because there's something not appropriate. And when you clear C1, I always like clearing C1 the first, because any change of increased tone in the paravertebrals and any change of proprioception, C1's one of the, most powerful bones that you can, or innervated areas that you need to pay attention to first. Okay, any questions?
How many techniques involve just C1 adjusting?
Oh, I think that I know of like 5.
Yeah.
Okay, there's probably a lot more. Okay, and it is so vital, particularly, when I bring up a case that has had 13 neck surgeries and there's only C1, or the muscular dystrophy patient that comes in here whose neck is almost fused, okay, in massive scoliosis, C1 is incredibly vital. Okay, good.
Yeah.
Is do a motion. So what you're going to do now is do a motion cervical check. Okay, you're going to support, line up, look at here, and make sure, because I'm going to see how much pressure you're putting. Also, I want to make sure that the feet aren't turned or rotated. Make sure your head's looking right down on the plane so you have an appropriate line of sight. Okay, and check to see if there's a change on motion.
Cool.
Okay. So some of the things that you want to make sure that you're doing, okay, is head posture, and this is going to be the cervical challenge on top of the challenge. So you've done the cervical challenge, you've assessed it, Check the leg length, you've seen it even out, you've done the toggle, okay, or whatever adjustment. Hopefully it is going to be a toggle because that's going to actually move it beyond that paraphysiologic range of motion. When you go to recheck, make sure, now watch his head. If I push up too much, see his head move? Mm-hmm. Yeah, that's putting too much sensory input into the body. So make sure when you're checking the leg length that you're right underneath. So your thumb is right underneath where there'd be a heel. Okay, and you're putting just enough pressure to put this shoe, because right now it would be really long. Right there it would be shorter. Okay, so you want to have that shoe up tight, and then you want to have your eyeballs right straight over, so you can see if the feet are like this, okay, like that, or even. Okay, but make sure when you put in that you're not pushing up so much that his head's moving. Okay, and I'm telling, that is good pressure, that's not. So there's only about a half a pound of difference there that you can mess up. Okay, now the question was brought in, what if it's a tight calf? What if it's, does a tight calf indicate a posterior ilium? Well, no. There's a lot of different factors, okay? And when we go over the biomechanics of the foot, the intrinsic muscles of the foot, how that is essential, but also when we look at the muscle ratio of a normal calf and pathologies that can relate, and then if you have a flattening of the foot, does that indicate that there may be some compression in the low back? Absolutely. So there's a lot of different factors down there. We're just going with the real basics, okay? Okay. Any questions so far? Okay, good. Here, haul it over here. So what we're going to do, we're going to go through stuff that we haven't covered yet, okay, on a patient. Okay, now here's the right side, here's the left side. What we're seeing is the left convexity, apex L1, right convexity, apex L3. When we look at this, we're looking at a right lateral shift along with a left rotation here and a right rotation in the upper neck area. We're looking at forward head carriage and some rotation down through here. And at the low back, we're also looking at a compressed disc at L5S1. So we're going to go through how to assess that. Now, what you might also take note is the femur heads. The femur heads are off, so that means he has an anatomically short left leg, or he has compressed nerves here causing a flattening of the foot on the left, or he's got some type of digestive anomaly or compression of the nerve, which is weakening the production of the cartilage and meniscus, causing a short leg. So you can measure the short leg. If it's, say, for example, 10 millimeters, it might not be 10 millimeters after you restore the nerve supply, restore the intrinsic muscles of the foot, regenerate cartilage and meniscus in the knee, which is all possible. So you don't say, hey, that's short, let's give him a lift. Make sure that you do some more accurate assessments after you get the correction. Okay? Okay, good. So we're going to assess him. So first off, I'm going to check the paravertebrals. And this is checking the increased tone of the paravertebrals. And sure enough, he has an increased tone on the left-hand side. You can almost see it from where you are. This is low and this is high. Okay? Then I'm going to check in an oblique angle on either side, okay, the pelvis, to look for some type of restriction, whether it's the pelvis ilium or a sacrum. Then, once I check that, I'm going to check upper cervical after I check the leg length. So, and then I'm going to turn him on his side, adjust, I'm going to do an anterior on him. We're going to do everything to check, but I'm going to do it in real time so you see how much time what we've just discussed takes. Okay. So, real time, you're just checking leg length. Okay, I'm just going to apply a little pressure here just for a second. Yeah, sure enough, that evened out. Okay, now this is going to be a meningeal release where I'm going to support this. I'm going to drive at a slight oblique angle, release and pressure. Go on your side, face me, sir. Now this is going to be a C1 toggle. So very, very easy. Pisiform contact. Come in. Now, since he has a left convexity, again, press neutral, get down to where he is, apex L1. Okay, go right on your back. Okay, now, he's got a left lateral shift. I already adjusted him. Yeah, but I'm going to apply a little bit of pressure. I'm holding him in a mirror image, neutral, and then a small lift in that direction. Just holding him for a second. Yeah, that one's all good. Now here's an anterior lumbar with a left rotation. So I'm cupping his head. My back leg lifts up. I'm push off of the table to save me. I contact flat hand on the lumbar, rotate over, and apply pressure in that direction. Now, since he's got a slight rotation in the front, I'm grabbing the table and applying pressure in that direction. Rise up, sir.
Thank you, doctor.
That's
Cool.
real time.